In 1818, James Blundell performed the first successful human transfusion, establishing the procedure as a direct transfer of volume to combat life-threatening hemorrhage. Modern civilian practice rarely utilizes whole blood, as it is widely regarded as an inefficient use of a strictly limited biological resource. Historically, clinicians aimed to maintain a patient's hemoglobin level at a baseline of 10 grams per deciliter through aggressive transfusion. However, evidence now shows that targeting this 10-gram threshold correlates with higher patient morbidity and mortality compared to lower target values. This risk stems from the immunological price of donor blood. The introduction of heterological cells leads to decreased survival rates in trauma and oncology patients. This chart maps survival against hemoglobin levels. In non-bleeding, asymptomatic patients, a hemoglobin level of 6 grams per deciliter is the accepted baseline for safety. Current medical guidelines treat transfusion as a highly restricted tissue transplant rather than a simple replacement of lost fluids. To manage the immunological risks and scarcity of the supply, medicine deconstructs whole blood into specialized components, only recombining them when specific physiological survival demands it. Fractionation uses centrifugation to separate blood by density into 3 functional layers: dense red cells, a buffy coat, and liquid plasma. The bottom layer consists of packed red cells. These units are concentrated to a hematocrit of 50 to 70. Plasma requires storage at -40 degrees Celsius and provides the source for cryoprecipitate, a concentrate used specifically to treat low fibrinogen states. Platelets are also extracted and supplied as pooled concentrates to treat patients with dysfunctional or low platelet counts. Unlike other blood components, platelets require continuous agitation at room temperature and remain viable for only 5 days. While fractionation maximizes the utility of every donation, it results in a fragmented inventory, where each component requires a distinct, often incompatible storage environment. In 1901, Carl Landsteiner identified the strongly antigenic proteins on the red blood cell surface that dictate immune compatibility. The ABO system is governed by 3 allelic genes, determining the cell surface architecture. A and B genes synthesize enzymes that add specific carbohydrate residues to membrane glycoproteins. The O gene is an amorph, producing no enzymes, leaving the cell surface chemically blank. The immune system produces naturally occurring antibodies against whichever antigens are absent from its own cells. Because Group O cells lack these antigens, they function as the universal donor. Group AB individuals, possessing both antigens, produce no such antibodies and can safely receive any ABO blood type. Introducing an incompatible antigen triggers an immediate immune response, rendering a life-saving infusion a systemic threat. An ABO mismatch results in complement-mediated intravascular hemolysis, the rapid destruction of donor cells that leads to multiple organ failure. The second major compatibility pillar is the rhesus D antigen, which is present in roughly 85% of the UK population. Rh antibodies are not naturally occurring. They are acquired after an Rh-negative person is exposed to Rh-positive red cells. Once formed, these antibodies can cross the placenta during pregnancy, potentially causing fatal hemolytic anemia, or hydrops fetalis, in an Rh-positive fetus. To prevent these outcomes, laboratories perform a cross-match by mixing recipient serum with donor cells to confirm compatibility across all major antigen systems. In emergencies where a 45-minute cross-match is impossible, clinicians utilize O-negative blood, the universal donor, to stabilize the patient immediately. Cross-matching acts as the final safeguard, ensuring the fractionated supply is immunologically safe before it enters the patient. In cases of massive hemorrhage, the clinical focus shifts to damage control resuscitation, where speed is prioritized over standard matching. The traditional response involved rapidly replacing lost vascular volume with only crystalloid fluids and packed red cells. This animation shows the result. Large volumes of fluid and red cells dilute the plasma, scattering native clotting factors. This coagulopathy prevents a stable fibrin mesh, allowing continued bleeding. Trauma patients often enter a state of hyperfibrinolysis, where the body aggressively dissolves whatever clots do manage to form. Clinicians combat this by empirically administering tranexamic acid to inhibit the breakdown of fibrin. To fix the structural deficit of the blood itself, trauma teams now employ the 1:1:1 balanced transfusion regime. delivering units of red cells, plasma, and platelets in an equal ratio, mimics the composition of whole blood and prevents the onset of dilutional coagulopathy. Teams may also use point-of-care thromboelastometry to guide the specific replacement of fibrinogen using cryoprecipitate. Modern damage control resuscitation is a calculated, real-time chemical reconstruction of whole blood designed to forcibly halt systemic bleeding. Maintaining a functional blood supply requires a massive logistical infrastructure for donor screening, infection testing, and storage. Even with this infrastructure, medicine faces the persistent dual risks of immunological complications and supply exhaustion. To bypass these biological constraints, researchers are developing synthetic blood substitutes. One pathway focuses on biomimetic substitutes engineered from free hemoglobin. These molecules carry oxygen without the cell membrane antigens that normally trigger an immune response. A second pathway utilizes abiotic substitutes, synthetic perfluorocarbon emulsions that transport oxygen independently of biological proteins. Second-generation perfluorocarbon emulsions are currently demonstrating significant potential in advanced clinical trials. The future of damage control resuscitation lies in these synthetic carriers, offering a way to deliver life-saving oxygen without the immunological costs of human blood.